Mainly, we'll talk about number one, what is Parkinson's? What are the signs and the symptoms? We break them into two different groups. You know, what are the motor or visible signs or symptoms? What are the non-motor or the invisible symptoms of Parkinson's? And then we'll touch a little bit just on the basic treatment strategies, not to go into all of the medicines in depth, but just basic strategies and options. Next slide. So throughout the presentation, we're going to show a bunch of photos and pictures, and really the theme here is that no two people with Parkinson's are alike. Young, old, black, white, male, female, you know, all comers. It's as much as we think about the 85-year-old Caucasian man with Parkinson's. You know, many people think about Pope John Paul II as sort of the poster child for Parkinson's and what it should look like. We're going to learn that it's quite different, and it affects a lot of different people. Michael J. Fox, for example, was 27 when his symptoms started. He's done more to raise awareness and money for the fight than anyone, and so you can never give a talk without recognizing his efforts. Robin Williams, the famous comedian and actor, you know, had some form of Parkinson's. It may be debatable whether it was Lewy body dementia or perhaps he was also using a lot of drugs. Yeah, that's one issue. I think many people have seen that in the not too recent past, Alan Alda or Hawkeye Pierce from our show MASH disclosed that he had developed Parkinson's as well. Next slide. The people ask all the time, you know, what are movement disorders? What is a movement disorders specialist? Well, you know, we assess movement, and really there are two options here. People are either moving too much or they're moving too little. We're going to focus our attention on the people who are not moving enough, or what we say is akinetic rigid, or perhaps the term Parkinsonian. Which also then means that there's a lack of movement, a paucity of movement. Some folks that have the other conditions that are moving too much, or those are hyperkinetic disorders. Some of you may have heard of a condition called Huntington's disease, and that's sort of the hallmark disease where people are having all these extra squirmy and wiggly and jerky movements that look quite different from Parkinson's. Next slide, please. So when we say somebody looks like they have Parkinsonism or they're Parkinsonian, you know, what does that mean? Well, it means typically that they're slow, they're stiff, they're shaky, their movements, you know, are much different than what they're supposed to be. But it's not a definition, it's not a diagnosis. You know, Parkinsonism is just a term, so then you have to search for the cause. Well, the most common cause of Parkinsonism is indeed regular Parkinson's disease, which has a very specific pathology that we'll talk a little bit about. It's also very important to consider what medications and potentially what drugs have some people been exposed to, as many different medications and drugs can cause all the same symptoms that Parkinson's disease can cause. Some of these medications can include some of the strong nausea medicines, as well as some of the psychiatric medicines used to treat schizophrenia and hallucinations. There are also a whole host of what we call Parkinson's plus syndromes, or atypical Parkinsonism, as some people may have heard. And these are sort of the cousins of Mr. Parkinson. They look a lot like him, but they each have their own sort of nasty feature that usually makes these a little bit more dangerous and more difficult to treat than regular Parkinson's disease. Next slide, please. So here's another sort of glimpse of who Parkinson's has touched. You know, like I said, the young, the old, the white, the black, the pious, the evil. You know, it touches everybody. You know, most of you will recognize the people here, and various forms have you know, shown that they have Parkinson's symptoms or have disclosed that. Next slide, please. So in 1817, James Parkinson, a physician in London, described the disease that now bears his name in his famous essay on the shaking palsy. It's wonderfully written. He spent 8 or 9 years following the course of 7 patients with Parkinson's disease and really documenting, everything that he was seeing and observing, all the symptoms, how people were acting and behaving, and it's a really, really neat read. It's a disease that affects about 1 million people in the U.S. right now. So you think about the prevalence and the incidence of it. Again, 60% of them tend to be men, 40% women. Parkinson's disease is idiopathic. That just means that we have no idea what causes it. It's our fancy doctor speak. But the dopamine neurons, the brain cells that produce this chemical called dopamine, they start to slowly die off in a certain part of the brain. The dopamine, the best analogy I can give is if you imagine the movie The Wizard of Oz. It's the Tin Man who can't move, he can't walk, he's very stiff. And what gets him moving? What's the oil can? Well, dopamine is that oil, or the medications we use attempt to replace that oil to help make the movement more fluid and more natural. The hallmark diagnosis of Parkinson's disease is made after death at autopsy, where we find these pink protein deposits in particular parts of the brain. These protein deposits are called Lewy bodies. In the next slide, we'll see some slides that will show on the bottom right, you can see that nice pink circular, that is the Lewy body. And so I think it's important to frame here that this does not mean that Parkinson's is Lewy body disease or it's going to become Lewy body disease. These are two distinct diagnoses, two separate diagnoses. The difference is that in Parkinson's disease, we find these Lewy bodies really more restricted to certain areas of the brain, such as what this cross-section of the brain is showing at the top in the substantia nigra. Whereas in Lewy body dementia or Lewy body disease, we find these Lewy bodies all over the brain, really spread out throughout. So again, they're distinct diagnoses with very distinct clinical features, and not necessarily one becoming the other. Next slide, please. There is a brain scan that's been commercially available for maybe just under 10 years now. It's called a DAT scan. And what it does is it images a very deep part of the brain where those dopamine neurons live. And so what these scans can show us is the activity of those areas. So what we do is we inject a substance into the arm that this area of the basal ganglia really likes, and it soaks it up. It's actually an analog of cocaine that is injected. But when you think about drug abusers, they get this this euphoria, the sudden release of all this dopamine when they use cocaine or whatever it is that they're abusing, and that comes from the basal ganglia. So by injecting this stuff, that part of the brain just soaks it up, and then we take some pictures with a SPECT camera, and it should light up nice and bright, like you can see the image on the left. The way it's referred to is you can see the nice circular portion sort of at the front, and then the sort of curvy part coming back. That's been described as sort of a semicolon. Some people, especially where I grew up in Augusta, Georgia, will call that the golf ball and the tee. But you can see the image on the right in the person who has Parkinson's. You can see that signal has faded out. It's not soaking up the tracer quite as robustly, and hence the pictures are not quite as bright. Next slide, please. Still, though, the gold standard, the hallmark way to diagnose Parkinson's is with an autopsy. We've gotten better and better at diagnosing it earlier and earlier. I think when you look at, a DAT scan is about 94% accurate. They say movement disorder specialists like myself are about 94%. So I guess that could be replaced with an image now. But We think about general neurologists, they say they're about 80% correct in the diagnosis, and primary care doctors are somewhere in the 60s. But so the way we do this, looking at the next slide, is that we have to do it the old-fashioned way, and we have to listen, we have to look, we have to examine people, and we look for first of all the cardinal motor features, one of which is the resting tremor. A resting tremor implies that the hand or the leg or the jaw starts to shake in a position where it is at rest and not when it's being moved. So often people will be sitting watching TV with their hands in their lap, and they'll notice that one of their hands is shaking. But when they go to move their hand and grab the remote control or pick up their drink, the shaking stops. And because it's in action. So that is the classic resting tremor that we see in Parkinson's disease. Bradykinesia means slow movement or a lack of movement or a poverty of movement. So as opposed to, say, stroke victims who become paralyzed on one side of their body, Parkinson's makes the natural movement slower and stiffer, choppier, if you will. Again, think about the Tin Man. Cogwheel rigidity is something that we can appreciate when we're examining people in the office, where we're, manipulating your arm or your leg, and we're kind of twisting your arm around in different ways. You can feel this resistance to passive movement, and this is a feature. It feels almost like gears are grinding when you're kind of moving the limb around. And then finally, the fourth cardinal feature is postural instability or balance issues. It's typically something that comes over time. It's usually not the first symptom. Very early balance problems really make me nervous about one of the atypical Parkinsonisms, or something that's called PSP, or progressive supranuclear palsy. It's a sort of a more malignant form of Parkinson's, if you will, but people fall from day one. But so it does happen in Parkinson's that the balance is affected. It's usually not early or the first thing. Next slide, please. So what are the non-motor features, or the invisible features? And in my Parkinson's clinic in Georgia 15 years ago, we did a survey, and the question was one question: what is the most disabling symptom that Parkinson's has given you? And my partners, my colleagues, and I were sort of taking bets. Is it balance? Is it tremor? What is it? What are they going to say? And I'll tell you that 60% of the people came back and said that it was their mood, it was their emotions, their depression, their anxiety, their fatigue, their hallucinations, those types of things. And I think it's important to realize that people who feel anxious and depressed, it's not a sign of weakness. It's not a sign that they're feeling sorry for themselves. It's the very same thought that the dopamine that controls the movement also has a profound impact on the emotions and how we process things. So, a lot of cognitive and psychiatric symptoms can manifest in Parkinson's. We see a lot of changes in how people think. It's slow thinking or slow processing. We see sleep fragmentation. Some people develop horrible insomnia. Some people have nightmares and they're hollering and screaming in their sleep. Some people develop hallucinations. Many of you have probably seen there's a horrible commercial that comes on TV now that a clever drug company has put out there because they're trying to market a drug for it. That's very expensive, but it's horrible. It scares everyone, and I get more phone calls when my patients see that commercial than for any other reason, I think. But as many of you know, that Parkinson's can affect a lot of other parts of the body, what we call autonomic effects. So blood pressure is a huge thing. And, we always check your blood pressure when you're sitting down, but then we have you stand up for a minute or two and then recheck it, because in Parkinson's, the regulation of the blood pressure can start to go awry, and the blood pressure can start to drop unexpectedly or for no reason at all. And it can make people feel really dizzy. It can make people pass out. A lot of different things can happen. Some people, though, won't even report feeling dizzy because it's not dropping enough that they're getting dizzy, but they report just feeling fatigued, or they're having slowness of thinking, or they're having some of those other issues that that prompts us to monitor the blood pressure. So it's important to pay attention to that. People develop a lot of different sweating abnormalities. Some people stop sweating. Some people have drenching sweats. Some people can develop skin changes, or the skin becomes more oily or more dry. Constipation is a very common problem in Parkinson's. Just as the movements in the hand and the feet and the legs can get slower, well, the GI tract can also slow down. So this is something that a lot of my patients will spend a lot of time talking about, because it can really affect quality of life. You can see sexual dysfunction both in men and women from Parkinson's, and also just a lot of unusual sensory feelings and pains, strange vibrations, strange sensations, strange smells. You know, in my nose, there's a burning smell or a lack of smell. So a lot of things. So Parkinson's doesn't just cause tremors, it causes a lot of different issues. And it's important to talk about these, because the dopamine type medications that we use to treat movements don't usually help here. But there are a lot of solutions to these problems. And so engaging our patients and having our patients bring these issues to us is helpful, because again, these things all impact quality of life, and there's often a lot we can do to improve things. Next slide, please. So here are a number of musicians who have been diagnosed with Parkinson's, and many of you will recognize people like Ozzy Osbourne and Linda Ronstadt. There's, let's see, who do we have here? We have Maurice White from Earth, Wind and Fire. We have Johnny Cash in the middle, and then there's Neil Diamond at the bottom right. But again, Parkinson's affects a lot of different kinds of people. Next slide, please. So we talked about the atypical Parkinsonisms, or the Parkinson's mimics, or the cousins of Mr. Parkinson, as my mentor used to like to say. But PSP, we touched upon, progressive supranuclear palsy. People lose their balance very early. They fall constantly. They usually don't have much tremor. We think that Dudley Moore, the famous actor, probably died from PSP. MSA, or multiple systems atrophy, is a situation where people develop some slowness and some stiffness in their movements. It looks a good bit like Parkinson's, but they start developing a lot of those autonomic issues. The blood pressure is a huge problem. I mean, my patients with MSA, they're calling me because every time they try to stand up, they just about pass out. Their blood pressure drops to like 60/40. And so we have to do a lot to actually put people on medicines to raise their blood pressure. But they also develop a lot of other issues with like incoordination. That's a little bit different from Parkinson's, something we call ataxia. Corticobasal degeneration is another condition where people get, you know, slow and stiff, but kind of more jerky. They have a lot of myoclonic jerks, and there's something called alien limb phenomenon, where, you know, one of their arms will just sort of start drifting off or up in the air or go behind them, and then they're not even aware that it's happening. It's almost like it's got a life of their own. And I remember one of the most dramatic examples I saw in one of my patients was that every time he would try to dress himself and button up his shirt, his other hand would come right behind and would unbutton it. And it was just, you know, the most unusual thing. Dementia with Lewy bodies, if you will, it looks like a combination of Alzheimer's and Parkinson's. The important feature here is that the cognitive changes, the memory loss, the hallucinations, you know, all those things are usually start first. And then they develop some of the movement problems, like the slowness or the stiffness or the tremor. But usually the movement stuff comes a little bit later, at least a year or so after the cognitive issues. But people with Lewy body dementia, they have wild fluctuations in their cognition. One of my patients happens to be a PhD engineer, will come in and talk to me about, you know, how the space shuttle, how they make the space shuttle kind of, you know, blast off and go into space, and how all these things happen, and telling me all these things that I barely can understand the physics behind what he's telling me. And then he'll go home and his wife will call me because he puts his shoe in the refrigerator when he takes it off instead of on the shoe rack. And so, I mean, we see wild fluctuations in people with dementia with Lewy bodies, and also really vivid visual hallucinations. The vascular Parkinsonism that Dr. Edwards mentioned also can look like Parkinson's, because what happens is people have a bunch of tiny little strokes in the same area of the brain where the dopamine is produced, where that area dies off. In regular Parkinson's, here it's killed by small strokes that happen over time. So if you get an MRI scan, you'll see all these little strokes kind of riddled throughout that area, whereas the MRI in a typical Parkinson's patient usually looks normal because you can't see the underlying damage. Normal pressure hydrocephalus is a condition that we call water on the brain, or NPH. And what happens is the brain fluid that we all have in certain parts of the brain, in these different cavities that we call ventricles, sometimes there's too much fluid causing too much pressure, and it kind of blows that area up. And what ends up happening is it puts pressure on certain parts of the brain that can affect your walking, and it can make your gait look very Parkinsonian, like you're shuffling your feet or your feet are sticking to the ground. But it also causes a lot of trouble with memory loss as well as incontinence, and there's a surgical procedure to drain the fluid that can essentially cure this problem. But a lot of people who are diagnosed with Parkinson's ultimately go on and you get a scan and you see, wait a minute, this isn't Parkinson's, this is NPH. Wilson's disease is a disease of copper metabolism. It's usually in younger folks. So any young person with a movement disorder, we should always screen for this because it can be cured. But people with Wilson's disease can often look Parkinsonian. But again, we talked a lot about medications and drug-induced Parkinsonism. Always screen the med list because there are certain things that can cause all the same symptoms. There are even some heart medications, some anti-arrhythmia drugs used to treat AFib and other arrhythmias can actually cause all the same symptoms of Parkinson's. So it's important to look at those. Wouldn't it be great to stop a medicine and cure the Parkinson's? Next slide, please. Here's a photo of the so-called frozen addicts. In the early 90s, these folks were trying to manufacture their own version of heroin, and they got pretty close. They were able to enjoy and get high off of whatever they created, but what they created had a little bit of an impurity in it called MPTP. And MPTP is basically poison to the basal ganglia where the dopamine is produced. And so it instantly, basically killed that part of the brain in all these people, and they very acutely became Parkinsonian. You can see their masked facial features, and in other videos you can notice the way they're walking and moving. But interestingly, their mistake in creating what they were hoping was going to be heroin, their mistake has actually led to a lot of research in Parkinson's, because they give this MPTP now to animals to create animal models of Parkinson's, so that different therapeutics can be tested to see if it improves the symptoms or not. So a lot of what the mischief that they got into has actually been very helpful in research. Next slide, please. This is one of my favorite pictures here of Muhammad Ali or Cassius Clay, I think at the time, kind of towering over Sonny Liston. And you think about the beauty, the grace, the athleticism, the power, and then you fast forward and see, what Parkinson's did to him. But what an amazing man and picture. And some of you will recognize over on the right, that's a baseball player. It's Kirk Gibson from the LA Dodgers. And this is an iconic moment from the World Series. His only appearance in that World Series that year was a ninth inning at bat where he hit a home run to win the game, and he wasn't expected to play because he had basically blown out both of his knees. But he now has Parkinson's. Bottom left is Brian Grant. He is a former basketball player. When he turned 37, he started developing symptoms. He played for the Phoenix Suns. I think he won a championship with the Miami Heat. I think their first championship. But he has a big foundation now doing a lot of work to try to help cure Parkinson's. And then bottom right, this is Sir Roger Bannister, who's the Englishman who broke the 4-minute mile. Not only did he do that, but he was also a neurologist. believe it or not. But he ultimately did go on to develop Parkinson's disease. Next slide. So we get to treatment. This is my silly cartoon to kind of segue there, but it's not terribly untrue. I mean, you look at the cost of so many of the therapeutics we have, and I mean, it becomes absurd at some point. But anyway, next slide. So how do we treat Parkinson's? Well, I mean, first and foremost, it's important to know, just like with Alzheimer's, there is no cure at the moment. We do not have a cure. We don't have any agents that we know predictably will slow the progression of the disease over time or slow the death of those neurons in the brain. But there are a lot of things that we can do to approximate that. So first off, anyone who's ever been to my office or to an appointment with me knows that we talk a lot about exercise. And every doctor you go to is going to tell you to exercise because it's good for you. But for Parkinson's, it is almost magical. Exercise is the only thing that I can prove to you with clinical data that can slow progression of the disease. And it's hard to imagine, but it's true. The more people exercise and specific kinds of exercise, the more we see that not only are their symptoms better controlled and less severe, I have patients who over time have been able to reduce how much medication they actually need. So it's a very powerful part of our treatment. It's not just a recommendation, it's part of the treatment now. There is one medication called rasagiline or Azilect that there is some small data that is suggestive that it may slow progression, but we can't prove it for sure. There is one small clinical trial that sort of suggests it. Half of us buy into it, half of us don't. From my vantage, the medication's not dangerous, and if there's not a contraindication to giving it to somebody, I'll usually have the discussion with them, might we try it? It's not the most robust medicine in terms of treating symptoms. So if somebody is having a lot of trouble walking or has a really bad tremor and they need help, I'm not going to use rasagiline to treat it. But we often will talk about it as potentially slowing the progression, although we can't prove it. We focus a lot of time on symptomatic therapy, both for the motor and the non-motor features. So, we've got a lot of medications that help people move better. For people that have tremors, we have a lot of stuff that will calm down the tremors. For people that are just really slow and stiff, we've got that oil can, the levodopa, that to replace the dopamine. But for people who have the non-motor features, the depression, the anxiety, the cognitive issues, the blood pressure problems, and this is where it really takes a team approach. And one of the reasons I'm just so terribly excited to be part of this clinic here, but to have the specialists here like Dr. Edwards and Dr. Shepard or a psychiatrist, I mean, to have folks like that who can readily jump in the room and help me when these things are going on, I feel like we can much better handle the issues that are at hand. Because it's really not just a movement disorder. It's a lot of other things as we've seen. But you really have to individualize the treatment and tailor the treatment to each person because no two patients are alike. The youngest person I've ever diagnosed was 26 when it started. Her treatment plan is much different than someone in their mid 70s when I diagnosed Parkinson's, because obviously, I mean, I'm going to be treating one of them for a lot longer than the other. But you think about how do these medications affect young people versus how they affect older people? What are the risks involved? There are certain surgical procedures that we use to treat Parkinson's, and who are good candidates for them. And so again, it's very important to look, listen, and learn from your patients. And I try really hard to do that because again, most people, if you give them time and you listen hard enough, they're going to tell you what's wrong with them, whether they realize it or not. But you just got to pay attention, and then you try to figure out how do we help. Next slide, please. And so this is the end of my formal comments, and I think with Dr. Edwards, it only took him 30 years to realize where all the action really is, and so this is my tribute to Chuck. So with that, I think we'll end the formal part of the program.